Again, my name's Allie. I'm the co-chair this weekend. I hope you're having a good time. I'm excited to introduce our second panel, and one of the people up here, Priya Agarwal, was unable to make it. Our second panel is A Changing Landscape, Reproductive Health, Abortion Rights, and Maternal Mortality. We have some excellent panelists joining us for the conversation. A moderator is Dr. Anna Langer, professor of the Practice of Public Health, Emerita, Department of Global Health and Population. And our two panelists are Yuki Davis and Colleen Amanda Reynolds. Yuki is an MPH class of 2020 and is the board co-chair of the Eastern Massachusetts Abortion Fund. Colleen is SM in 2020 and is currently studying for her PhD in epidemiology here at the school. Take it away, Dr. Langer.
Thank you. Thank you so much for the invitation, and I'm delighted to be here with my distinguished colleagues on this panel. Sexual and reproductive health and rights have always been a very, very important dimension of people's lives, always and everywhere. But sexual and reproductive health and rights issues don't affect everybody the same way. They are not fairly distributed. The issues around sexual and reproductive health and rights, there's some people back here that can't hear. They cannot hear. They told me that the mic was on. Can you hear me now? Yes. Okay, wonderful. So we will speak very close to the mic, please. So I was saying that sexual and reproductive health and rights issues don't affect everybody the same. They are not equally distributed. Because of sex, gender, and other social determinants of health, the burden of sexual and reproductive health issues and the lack of the ability to fulfill sexual and reproductive rights mostly falls on women and other vulnerable population groups that are one way or the other at a disadvantage, socially speaking. So sexual and reproductive health strongly influences key dimensions of human life in general. To start with, sexual SRHR, if you don't mind my using the acronym, is too long to say the full words, influences the health of women throughout the life course, and also influences, of course, the health of the family, of the children, communities, and even the opportunities full societies or countries have to thrive and develop. Fertility, which is at the very core of sexual and reproductive health, is one of the key pillars, one of the key 3 pillars of population dynamics, along with mortality and migration. So it has a very, very important, it's very important globally. And reproductive rights that have been fully recognized in multiple international documents are highly politicized, highly polarized, highly polarizing, I would say, and in fact, very controversial in some cases. And whenever an individual is not able to fulfill the reproductive and sexual rights, that affects their ability to make decisions about their sexuality, about their reproduction, and about many other aspects of their lives, creating also challenges to health systems and societies. Sexual and reproductive health and rights, as I said before, is very, very closely linked to social determinants of health. So as it was said in the previous panel, they need to be looked at through an intersectional lens. They are closely linked to race, to ethnicity, to socioeconomic status, to education, to age, to the built environment, to so many other factors. The field is very broad and very complex. It encompasses a number of issues that go from fertility, contraception, abortion, infertility, HIV/AIDS and sexually transmitted infections, gender-based violence, abortion, adolescent sexual and reproductive health, LGBTQ sexual and reproductive health and rights. So the field is really broad. And of course, because the issues are so complex and diverse, we cannot address them all. We will only focus on a few, but hopefully during the Q&A, we will be able to also address other issues you may want to bring up. So today we have the privilege of hearing from a very distinguished panel of alumni who were already introduced. And I will also join making some comments about maternal health, which I hope that the panelists who couldn't join us was going to address, but that's my field too. So I will add my words to what my colleagues here will say. And we will mostly talk about the challenges and opportunities surrounding adolescent and LGBTQ sexual and reproductive health and rights, abortion, and, as I said before, maternal health. We will address the evolving landscape in the US, but in a global context. Hopefully, we will be able to bring up some examples that show us how we are doing in this country compared to what's happening in other places. So I'll ask my colleagues to start by providing an overview of your perspective and expertise, including your own research about the topics you are working on. And if possible, also please mention some innovative approaches and solutions that you think could help address those issues. Let's start with Colleen. Colleen.
Hello, I am Colleen. I use she, they pronouns, and I am a doctoral student at Chan, wrapping up my dissertation. And my research really focuses on the sexual and reproductive health of LGBTQ people, particularly sexual minority women. And so by that, I mean women who identify as lesbian, gay, bisexual, as well as women who identify as heterosexual but have same-sex sexual partnerships or attractions. My dissertation research is really focused on documenting disparities in pregnancy loss. And by that, I mean ectopic pregnancy, miscarriage, and stillbirth. And in our research, we have been finding really striking and unsettling disparities. Just to highlight a few, in the Nurses Health Study 2 cohort, we found that bisexual women are 2.2 times as likely as their heterosexual peers to experience an ectopic pregnancy, 40% more likely to have their pregnancy end in miscarriage, and 30% more likely to have their pregnancy end in stillbirth. Not really sure if it's on. I think it's turning back on. So these disparities are even more striking among lesbian women, where we have found.
Yeah, please.
My apologies. So among lesbian women, we found that pregnancies are 70% more likely to be ectopic or tubal, 60% more likely to end in miscarriage, and nearly 3 times as likely to end in a stillbirth. I personally find these disparities really shocking, and we are continuing to replicate these findings into other cohorts, the Growing Up Today study and the Nurses Health Study 3. And what we found so far is that these disparities are even larger in those younger cohorts, which is really unsettling because these are women who are still in their prime childbearing years. And so these are women who are still experiencing these adverse pregnancy outcomes. More broadly, I am part of a team led by Dr. Brittany Charlton in the back that is focusing on these topics. And our team has found other really striking disparities. We found that sexual minority women are more likely to have preeclampsia, gestational diabetes, to have offspring who are born preterm or low birth weight. And among youth and young adults, we've also found that sexual minority girls are more likely to have sex with men as teenagers and are more likely to have sex at younger ages and with more sexual partners compared to their heterosexual peers. They're also more likely to get sex ed from their peers in the media, potentially because a lot of sex ed curriculum in this country is not inclusive of LGBTQ identities and experiences and needs. And as a result of these things, we have found that sexual minority girls are about 3 times as likely to experience a teenage pregnancy. And among sexual minority young adults, they're about 60% more likely to experience an unintended pregnancy, as well as more likely to experience an abortion. And so while these disparities are all really striking, I really do believe that there are so many opportunities for us to intervene to begin to address these disparities. And these range from advocating for comprehensive, inclusive sex ed across the country, really making sure that reproductive health care providers are adequately trained to care for their LGBTQ populations and patients, as well as expanding and ensuring, reproductive health rights and justice for all people with uteruses, as that would in its own way, benefit sexual minority women as well.
Thank you. Yuki?
Thank you so much. It's such an honor to be in conversation with both Dr. Longer and Colleen, and to be in a room with so many brilliant public health minds here. My name is Yuki. I use she or they pronouns. And I finished up my Master's of Public Health here in the fall, December, right on the cusp of the pandemic in 2019. And during that time, I focused on community health, health equity, and also the intersections of social justice and public health. And there are a lot of intersections with the topics of this panel and what I do in my day job, as well as my other responsibilities that focuses both on funding grassroots organizing around topics and issues of birth justice across the country, as well as funding and ensuring abortion access here locally in Eastern Massachusetts. But before I dive in, I just want to ground ourselves a little bit more in these frameworks of reproductive health, reproductive rights, and reproductive justice, because I find they're really helpful frameworks to know and understand kind of what are movements around abortion access here in the United States, and what are the solutions that we're working towards collectively to really ensure that access as well. And in everything I do, I just want to mention my work is all around uplifting bodily autonomy and aligned with the reproductive and birth justice movements through an approach that's really centered in relationship, in humility, and in compassion as well. So going deeper into these three different frameworks, a reproductive health framework really focuses on the direct services of an individual's reproductive needs, looking at this intersection of both the accessibility of services, insurance coverage, and then the clinical care itself, really working to improve outcomes, but also experiences in reproductive healthcare spaces, and focusing on that kind of point of care for a patient in the room. I think for me, reproductive health is so important and improving that care is so important, but I also always wanted to ask the questions of how did this patient get into this room? What are the barriers this patient faced in getting to the clinical care itself, as well as which patients and which individuals didn't make it into that clinical care point as well. So broadening out a little bit more, a reproductive rights framework really focuses on legal restrictions and the environment around laws and legislations that prevent individuals from accessing abortion, birth control, and other sexual and reproductive health needs. Legal access is proving increasingly important in the recent landscape. We really are seeing how the state-by-state legal system, as well as our federal law, legislative system, and court system is being manipulated as well as weaponized to threaten not only abortion access, but also gender-affirming care and trans rights and bodily autonomy overall. But again, a reproductive rights lens is limited in its scope in that just because something is legally accessible does not mean that that care, those services are actually accessible, equitably distributed, non-coercive, and are respectful, loving, and accountable and compassionate experiences for that patient as well. Which is where we bring reproductive justice in. And excuse me if you are already familiar with this framework, but just to give some context, the reproductive justice framework came out of the collective work of a group of Black women, previously known as the Women of African Descent for Reproductive Justice, which has since evolved into the organization Sister Song. It was coined in 1994 by these women who were organizing and responding to President Clinton's universal health care reform and how this proposed reform really didn't respond to how reproductive health care choices were often constrained by things like income, housing, and the criminal justice system. And so this reproductive justice movement really mirrors and brings to light a lot of organizing that has been done by Black and brown women, as well as trans and gender expansive people throughout history to ensure the right to have children, the right to not have children, and the right to parent those children in healthy and safe environments. And so access to abortion and other reproductive care and care that affirms individuals' bodily autonomy does not clearly rely on the legal or clinical context alone. And for those most at the margins, improving access to abortion requires addressing the structural and systemic barriers that are challenging that access overall, which is where abortion funds come in. Abortion funds, for those who are less familiar, are a wonderful mosaic of organizations and groups across the country that are meeting every person's holistic needs in accessing abortion and other care. So here in the greater Boston area, I work really closely with the Eastern Massachusetts Abortion Fund, and we work to meet every single one of our callers' needs. We do everything from paying for people's procedures, for hotels or flights if they're coming in from out of state, for their rides to and from the clinic, childcare, food, and post-abortion support needs. And this is how we're working to care not only for ourselves and for each other, but also for our communities. And again, those folks who are coming in and needing access from other states that are more heavily restricted as well. And through this work, we recognize that abortion impacts people at the intersection of many different oppressions, and that in order to really improve and guarantee access to abortion and other types of care that will uplift their bodily autonomy, we need to be addressing this from the intersections of class, transphobia, immigration, language access, citizenship status, economic status, disability, and many other issues and identities that all of the people who are seeking abortion hold. And that in addressing things like the impact of climate change, workers' rights, the medical industrial complex, police violence, the prison industrial complex, immigration reform, access to gender affirming care, and disability justice, we will not be achieving reproductive justice, and we will not actually be guaranteeing abortion access for all members of our community.
Thank you very much, Yuki. Now a few words about maternal health, and then we will start talking amongst ourselves and with you, of course. Well, maternal health refers to the health of people during pregnancy, delivery, and the postpartum period. And that is usually defined like the 6 weeks after delivery. But that period has been extended to 1 year, and you will hear references to pregnancy-related deaths that are now counted. Well, usually, luckily, this period is a pretty normal process and a joyful time for many people, but it's also a period of challenges depending on the person's circumstances, both biological and mental, social circumstances, and the ability or lack of ability thereof to get access to timely and good quality care. Maternal mortality, which is the extreme of the spectrum of poor maternal health, became the focus of the global community, probably most strongly in the year 2000, when the Millennium Development Goals were adopted, and one of 8 was fully focused on reducing maternal mortality. And that was because, well, it was recognized, and that recognition we still share, that maternal deaths represent the death of young people, and that at least 2/3 of them are preventable when people have access to quality care. So it's not only a public health issue, it's also a violation of the rights of every individual to get the health care they deserve. Also because we have the tools, the knowledge, as I said before, to prevent most of those deaths. So we need to make a special effort as a global community to make those tools and knowledge accessible to everyone in order to improve maternal health, which therefore represents like a good indicator of the health or weakness of a full health system. So the maternal mortality rates and trends have been very, very closely monitored since that year. And in most countries around the world, maternal mortality has declined with huge differences between countries. The country with the best maternal mortality rate changes every year, or with the worst for that matter. In 2020, which is the last year we have information from, Ireland was the country with the best maternal mortality rate, with 1 in 100,000 deliveries or live births. And in the worst rates you will find in sub-Saharan Africa and South Asia, where the rates are in the 1,000s. So the differences are tremendous, mostly because of socioeconomic circumstances and, as I said before, a strength or weakness of the healthcare system. So in the last decades, most countries have been improving their maternal health rates measured through maternal mortality, at least until the COVID pandemic hit. During the worst years of the pandemic, because the pandemic is not fully over, the maternal mortality increase had an upward stick in most countries that hopefully will disappear once things go back to normal, if you will. But in the US, sadly enough, the trend has been opposite. In fact, in the US, maternal mortality has been consistently increasing over the last few years, with huge inequities, differences between racial groups and people living in different geographic areas of the country, and by socioeconomic status as well. In the US, let me give you a few numbers just to make you aware of something that you may have read in the news, because luckily now maternal mortality and maternal health in general is receiving much more attention than some years ago. But currently, the US ranks number 122 122 among 186 countries listed from worst to best. So 122, the country that spends more money on healthcare in the world. And in fact, well, this is an interesting comparison. It's only slightly better than Iran and worse than the West Bank and Uruguay, just to use 2 examples. I could have used many more. In 2023, there were a total of 1,200 maternal deaths, compared with 861 in 2020 and 754 in 2019. So it's growing. The rates of maternal mortality are much higher among women aged 40 and more, but maternal mortality has been increasing at all ages. Sadly, there are, as I was saying before, great disparities in maternal mortality among different races and ethnicities. Rates of maternal mortality have risen also for white and Hispanic women, who are the ones who have best rates, if you will, in this not very good landscape. But Black women have by far seen the largest increase in maternal mortality in the last few years. In 2021, the CDC just published a report. The maternal mortality rate for Black women was 2.6 times the rate for white women, and significantly higher than rates for Hispanic women. In some states, the difference is even larger. For instance, in New York State, the difference is 5.5 times between Black women and white women, and in other states is even worse. Quick word about our work over the years. We had a project called the Maternal Health Task Force that is still active at the school, although I'm retired. What we did or what the program does is research on effective approaches to improve quality of care, strengthen social support in the communities, fill knowledge gaps in the field of maternal health that may be translated into concrete interventions, and measure the social determinants of maternal health. We also provide opportunities for dialogue, virtual and in-person, about maternal health and new exciting research and new advocacy efforts that are proven to be very effective, etc. And we advocate in general for more attention and resources for maternal health. So we'll stop here. I would be delighted to engage in a discussion with you about what's behind that very, very, that terrible situation of maternal health in the US. And there are some explanations and hypotheses.
Hi, Mia Lanigan, student. Can you isolate like one or two determinants that make like Black women in this country so susceptible to maternal death and complications and all these issues that happens? I know it's probably an amalgamation, but
Thank you for that question. Would you mind holding up for a little while? So we start with the previous panelists, but we will get there, definitely. So let me find my question for you. Yes, starting with Colleen. I wanted to ask you about the Healthy Youth Act, and if you think it would advance sexual and reproductive health and rights of LGBTQ people and other communities.
I would be happy to talk about that. So the Healthy Youth Act is a piece of legislation here in Massachusetts that was introduced over a decade ago, maybe about 11 years, which would basically require that if sex ed is taught, not requiring that it be taught, that it be LGBTQ inclusive, age appropriate, and medically accurate. This week, we actually had a phenomenal development on this front in that the Massachusetts Board of Education approved a new framework for physical and health education that would require that these are core competencies for when sex ed is taught, though we're trying to still pass the Healthy Youth Act to really put the force of law behind those requirements. Outside of the Massachusetts context, only 9 states, as of last year, so now 10 including Massachusetts, have policies that require when sex ed is taught, it be LGBTQ inclusive, and 6 states have policies that make it required that when sex ed is taught, that it be LGBTQ exclusive or discriminatory and homophobic, really invalidating LGBTQ identities. More broadly, 13 states don't require that sex ed instruction be age appropriate, medically accurate, or evidence-based, which on its own is shocking, but in the context of LGBTQ reproductive health is really an issue. In my mind, LGBTQ inclusive sex ed is critical because it does a couple of things. First, it can really normalize the existence of LGBTQ people and help reduce the stigma and bullying they face. I think some statistics that can really drive home that might be important would be some of Margaret Rosario's work, where she asked, young lesbian girls who were having sex with men why they were having sex with men. And 24% of these girls said that they were pressured by friends or family to have sex with a boy. 16% wanted to check if they were really queer, and 24% were trying to pass it straight. And so this is sex that many of these girls probably don't want to have, but because of the stigma they are experiencing, they are engaging in. And so just adopting a curriculum that acknowledges that queer people exist and normalizes our existence could really begin to start to improve health outcomes for these youth. It's also really important that all youth have access to the information they need to really make informed decisions about their bodies, and they know about the tools and resources to actually carry out those decisions. And I think by giving all youth this access, we could begin to address sexual violence, teen and unintended pregnancy, as well as a lot of other issues that are faced by the community.
Thank you so much. Yuki, you referred to abortion when you were describing those conceptual frameworks, but could you say a few words about how you see the situation after the Dobbs decision last year, particularly compared to what we see in other parts of the world?
Yeah, definitely. It's been a really difficult year, and it's been really devastating to see the lived impact of the Supreme Court's decision to overturn Roe v. Wade and the right to abortion in all states and across the country, and the implications for other sexual and reproductive health issues as well. Since last summer's Supreme Court decision, we've seen 14 states enact total abortion bans, and 25 million people with the capacity to give birth living in states that have some sort of restriction on abortion that has been implemented since Dobbs. We're also seeing an increase in attempts to criminalize abortion seekers and people who support people who are seeking abortion, and the actual criminalization of individuals across the country as well. And that includes really intense and difficult safety and security restrictions on different reproductive justice organizations across the country. I'm just coming from some work in Texas where I was hearing from different reproductive justice groups in the state that they've had to implement different safety and security protocols, even for the people working in nonprofits and not directly in clinics, which is not even to say kind of the threats that folks who are working in clinics and actually providing clinical care are facing. And all of these threats have also caused many clinics to have to close or move or limit the services that they're able to offer, which only restricts access to abortion even more. And then I'll just share from my own Massachusetts abortion fund. We are seeing increasing number of people coming from different states that have limited abortion, which just complicates not only kind of the cost of the procedure as they get further into their pregnancy and are trying to figure out what options they have, but also increasing costs around logistical needs to actually get to an abortion-friendly state. And that being said, Massachusetts is not the closest state to a lot of the states that have enacted abortion bans, and so folks are coming really, really far to just access the care that they deserve. And I think as we see abortion being restricted, there are many other different types of care that are also facing restrictions. I think to the point of maternal and perinatal health and birth, we're seeing more complications as folks are entering a pregnancy that they didn't necessarily want or that was medically safe for them. And we're also seeing increasing maternity care deserts across the country as many OBGYNs and other perinatal care providers are leaving their states to practice in more abortion-friendly states where they can actually practice to the full scope of their training. And we have so much to learn. I mean, Roe versus Wade was never ideal. Even with this so-called right to abortion in our country, there were so many people who were not able to access abortion or get their abortion funded by federal funding or through Medicaid with the Hyde Amendment that is still in place. So we have so much to learn from other countries. I think we see a lot of hope in the Green Wave movement in Latin America that's really focusing on increasing access to the right to abortion as both a part of other gender justice issues, but also focusing on it as a public health issue instead of an individual rights issue. And we've seen successes in Colombia and Argentina, and then most recently in Mexico as well, where the right to or abortion was decriminalized in Mexico very recently. And I think we have a lot to learn, not only in the frameworks that were used to push these really incredible victories across the line, but also the really intense organizing and cultural change that many of these activists were using to get these actual legal protections passed.
Thank you so much. A quick mention of the Green Wave. As you may have noticed, I have a heavy accent, and that comes because I'm from Argentina, and I also lived for many years in Mexico. And it's really amazing to see what's happening in the region, in a region that people identify themselves as Catholic in a large majority, but still using different arguments, they have been able to convince governments, Supreme Courts, Congresses, and using other mechanisms, of course, engaging with the community, and well, we're able to produce legal frameworks that are much safer for individuals who need to terminate their pregnancies. Before we open the question to the Q&A with everyone, let me answer your question or start answering your question. And well, it's very interesting because some of the things I'm going to say link very well with what my colleagues are saying. One of the things that explains the disparities and the high maternal mortality in the U.S. Or poor maternal health, let me say it more broadly, because it's not only, we are not only interested in preventing deaths, we are also interested in preventing morbidity and in making maternal health safe. So are the maternal health care deserts that you referred to. Now OBGYNs are closing their practices and small hospitals are closing in certain areas of the country, sometimes in states where the Black population is particularly large and are moving somewhere else. And now pregnant people don't have where to go when they have a complication, or they have to travel maybe 6 or 8 hours, drive 6 or 8 hours to get to the nearest hospital. In this country, we have a lack of midwives or primary care physicians or providers. They don't need to be physicians, they can be nurses or other healthcare professionals. And therefore, most of the obstetric care relies on doctors. And doctors, are often too proactive with interventions they use. And for instance, the very high C-section rates in this country contribute to poor maternal health and poor perinatal health as well, just as an example. The very weak social support network that exists in this country, Medicaid, which covers 41% of all deliveries, only extend the coverage to the first 60 days postpartum, and 50% of the maternal deaths happen postpartum. In some countries, that has been extended to a year, but in very few countries. I wouldn't be able to mention the names now, but maybe some of you know them. It's just a few states that have done that. Also, poor quality of care for Black and brown women, systemic racism, implicit bias, and the lack of a diverse workforce that people would feel more identified with, better identified with, are other factors that have been recognized. Also some biological factors that are more common among certain population groups, non-communicable diseases, overweight and obesity, C-sections I already mentioned, smoking and other addictions. Another social, the lack of an important policy that could contribute to better maternal health is that there is no mandatory paid maternity leave in this country. This is the only industrialized country that doesn't have a paid maternity leave policy. Paternity leave, less so, of course. Undocumented women, many postpone their visits to clinics because they are afraid of consequences on their situation in this country. The abortion restrictive laws, in addition to the great points that Yuki made, well, doctors sometimes don't understand the laws that have been recently introduced. So although they would, in theory, be allowed to terminate a pregnancy, they are not sure, and they are afraid of the consequences of doing it, that sometimes even include jail time and fines and other ways of punishment, and therefore they don't intervene, and the consequences are, sometimes traumatic for the patient. There are some good things happening. I wanted to finish this part of the conversation with some positive signs. As I said before, there is much more attention these days on maternal health than it was before, to a great extent brought up by journalists that denounce the situation in this country. ProPublica and other media outlets did a wonderful job at that, do a wonderful job at that. The Obamacare expanded coverage. The Biden administration just announced special funding for the improvement of maternal health. So we hopefully will get to a better place relatively soon, but we need to work hard to do it. So if it's okay with you, we can open now the floor to questions and comments from the audience. I saw some. one hand up and another one over there. Let's take 2 questions or 3 if there is someone else interested in asking one, and then we can answer those questions and keep going. Yes.
Thank you very much. First of all, I wanted to thank you for including this panel in the program. As an OBGYN, I'm thrilled to see women's health, discussed here. And as we mentioned, I wanted to mention I am from Poland, originally from Poland, country of one of the lowest maternal mortality rates in the world, close up to Ireland. And I have a question to Professor Langer. You mentioned in your statement that 2/3 of maternal mortality deaths are preventable. So my question is, what would be the factors that make the remaining 33% of maternal cases of maternal death not preventable, and what can we do as a public health, global health community to help in this aspect? Thank you.
Thank you. Yes. If you don't mind, sorry, could you mention your name and...
Yeah, Małgorzata Szlapowski, Academy Fellow from 96.
Wonderful, thank you.
Class of 2009, assistant professor at the University of Oklahoma Medical Campus. I have a question about, thank you so very much first, and I have a question to follow up the OBGYN doctors with the African states, from the states who have very strict trigger laws to the states that do not have such laws. So I was wondering, it's been more than 1 year already. Is there any study that observed worse maternal health outcomes in the states that have the trigger laws? Are you aware of any?
Thank you. Any other questions we can answer them all at the same time? Try to answer them at least. Yes.
Is there any advocacy work being done or an advocacy group that is specific to women veterans or women in the military, because their access is actively being blocked?
Mm-hmm.
And it's legislated under military health care and veteran health care.
Thank you. Would you like to start answering any of these questions? Or you, Yuki?
You're welcome to start as well. Yeah. Okay. I'm not aware of any specific groups working on veterans specifically in terms of abortion access. So curious if you know of any, but that's a really important point. And I know from my own birth equity related policy and advocacy, there are a lot of movements, and there's actually legislation to improve at least like perinatal care for veterans and folks who are in the armed services as well, through the Black Maternal Health Momnibus, which is led by Representative Lauren Underwood and Representative Alma Adams, and I think Senator Cory Booker in the Senate this year. And so there is some of that legislation. And I know especially the veterans legislation has been moving through and was signed into law last year. In terms of research, although it's really difficult to estimate, I know that there has been some research in terms of states with abortion bans and increasing maternal death rates. But also, it's so difficult to measure outcomes of missed abortions, especially when you're thinking about how folks show up to the hospital with miscarriages, because that is the safest way for them to seek medical care. And then just to the point of what can be done to prevent maternal deaths. I know that Dr. Langer has so much wisdom to share on this, but one thing I do want to add to the conversation is listening to people giving birth. I think we see a lot of stories of where the birthing person's story, concerns, risks are not listened to. And there are so many examples, unfortunately, of Black maternal deaths where Black women specifically weren't listened to. I think of Dr. Shalon Irving, who was a public health peer, Shaeja Washington, Kira Johnson and so many countless others that ended in death, and then so many other stories of Black women who nearly died because their doctors and their clinical care team were not listening to the concerns that they were expressing, which I think is rooted within so much, not only systemic racism within our perinatal care system, but also interpersonal racism, and just an overall lack of trust in each person to know what their body is doing, and when something is not going well.
Thank you. Thank you so much. Would you like to add a few words, Colleen?
You covered everything.
Does anyone in the audience know more about the situation of veterans in terms of, I think, new restrictions that are now being introduced? Okay, sorry, we cannot be more specific about that. In terms of your question about the maternal deaths that cannot be prevented, well, there are always complications that, as you know better than me, I'm a pediatrician by training, although I've worked most of my career on women's health. Well, there are some cases of preeclampsia and eclampsia that happen all of a sudden, and that even in good places are difficult to manage. And of course, if we talk about places where the resources are so much more limited, like in some of the countries with the poorest maternal health, of course, that's definitely higher as a cause of maternal mortality. Also, there are some chronic conditions that inevitably are difficult to manage, like cancer among women, or some cardiovascular complications that may lead to death and cannot be prevented. But if you think of the 5 major killers of people related to their maternal health process, hemorrhage, mostly postpartum hemorrhage, infections, complications of unsafe abortion, hypertension, and you never have to say a number, because then you forget one of the, I said 5 and now I forgot one. Infections, complications, high blood pressure, unsafe abortion, yes, I think I said them all. So those are the main causes of maternal mortality all over the world. And in the case of those causes, it's much more than 2/3. In other, that can be prevented. In other countries like the US or other industrialized countries, the only deaths that still happen are due to conditions that are really difficult to manage, or completely unexpected obstetric complications. And the third question that we got. Oh, yeah, I haven't seen any publication yet about that, but there is obviously a confluence of high maternal or poor maternal health in states that also have the most restrictive abortion laws. So this might just be like a perverse cycle. Things will get worse and worse in those places. But it's difficult to demonstrate. The lack of access to safe abortion services may produce morbidity and mortality by itself, but it also can produce higher morbidity and mortality through those indirect mechanisms, because women or people are afraid of going to healthcare services because of the potential consequences in places where abortion is restricted, and providers are not sure about what they can and cannot do to save their patients' lives. Any other comments or questions? If not, well, okay, yes, please, go ahead.
fertilization and surrogacy. And I was wondering what's the impact of this on these two areas, IVF and surrogacy?
Obviously, same-sex couples are much more likely to use IVF and surrogacy, in part because they often just don't have access to the correct gametes or anatomy to have a pregnancy naturally. And I think in this post-Dobbs era, we're really going to see a lot of these abortion restrictions are probably going to end up disproportionately impacting LGBTQ families, particularly given that there's some uncertainty about legislators wanting to make it harder to use things like IVF based on the status of the embryos. And so this is a point of like contention and risk, and I think is really going to open the door to further undermining queer people's abilities to form families.
And I think the only thing I would add onto what Colleen shared is that even before Dobbs, our perinatal care system and family formation practices have not met the needs of queer and trans families. And I think the more and more that these options for family forming that aren't necessarily kind of, additional options and offerings and opportunities to form family outside of heterosexual couples are just needed to be made even more accessible, because we only see so many people who are able to even afford IVF or other types of fertility treatments as well. And so I think overall we just need to make our entire perinatal care and birth system work for everyone who wants to form a family or to give birth.
Building off of that, I also think it's important to note that as more states start requiring that health insurance covers services like IVF, to access that, couples often need to demonstrate medical infertility, which is typically thought of as having unprotected heterosexual intercourse for the span of a year without conceiving, which can make it difficult for same-sex couples to get that diagnosis and get permission and health insurance coverage for IVF. And so there's a movement to factor in this concept of social infertility rather than a medical infertility to help same-sex couples gain access to that coverage. And as for other ways of forming families, I think it's important to note that 13 states currently permit child welfare agencies to refuse to place foster care children with same-sex couples if it conflicts with the religious practice of those child welfare agencies. So even outside of forming biologic families, same-sex couples really are at a disadvantage here.
Thank you. Yes, please.
I know you're closing the discussion, but both this panel and the panel run after lunch have been particularly interesting. They have largely characterized the United States experience, and these are, of course, global issues. So I was quickly looking up which are countries in which various forms of LGBTQ are criminalized, which are countries where the restrictions carry heavy criminal penalties, and which are those that are in fact moving in more positive directions. And just to mention them very, very briefly, we know Uganda, we know that Nigeria are getting much stricter. Uganda fully criminalized. They're not alone. I think it would be helpful to have the legal authority on this, but it's very interesting where they're actually moving in a more positive direction. And some are in the Caribbean, Barbados and Antigua and Barbuda, Singapore, but also Angola, also Gabon, also Botswana. So these are very fluid legal regimes and restrictive regimes. And it's simply to say that the US, and I'm sure it's also the UK European in this fluidity. And it's in that context also that Roe v. Wade is not only a US issue, it
global
reinforces,
issue.
the Supreme Court decision reinforces the far more conservative position of some, but it's great to see that others are moving in more positive directions, and of course we want to reinforce and support that. Thank you.
Thank you for that excellent addition to our conversation. These are really, really important points, and you are absolutely right. I mean, we live in a global community, and COVID was probably one of the best demonstrations that, borders, geographic borders don't matter when it comes to global health. And policies are also influenced across countries very much so. So thank you very much for that excellent contribution. I think we are about to end a very long day. So we'll probably stop here. There are so many other things that we could be talking about. We didn't talk much about other goals of the same individuals, institutions, groups that push for abortion restrictions, their efforts to limit sex education, their efforts to limit contraception, which is something that is almost unthinkable, at least for people like me who have been in this field, working in this field for some decades. But it's happening. So we need to join forces, and maybe let me finish a little bit along the lines of the last panel. We all can do things about, these setbacks that we are seeing, and seize the opportunities that good advances are providing, not only the US, but in other countries as well, and learn from each other and apply from each other and stay informed, and always, always, always support the most vulnerable people wherever they are. So thank you very much, and enjoy the rest of your afternoon. Thank you.